Dear colleagues, it's my pleasure to introduce Dr. Schumacher. Dr. Schumacher is a second-year resident in our department. He has studied at the University of Ulm, and afterwards he joined to our team. He will present today a talk about perioperative pain management, and we thank our anesthesia department for their help in preparing this presentation. Thank you very much. Dr. Schumacher, stage is yours. Enjoy the presentation.
Thank you very much for the kind introduction. Good morning, everybody. Today I try to put theory into practice by introducing an algorithm for perioperative pain management, which can help us for our daily work life here on our wards to treat the pain of our patients. I would like to start with a question for our residents and students. What do you think can be the consequences of increased postoperative pain? Yeah, please.
Bed rest, prolonged bed rest and complications like...
Exactly. Thank you very much. Postoperative pain leads to immobility, which is generally associated with higher risk for complications such as pneumonia or thromboembolism. Furthermore, stress comes from pain, and stress leads to a worse recovery and also then to in case of hemodynamic stability to instability. And the next thing is that especially in major surgery or after amputations, the risk for chronic pain is higher. And with a sufficient analgesia, we can prevent chronic pain. Then general patients with pain stay longer in our hospitals. This is also a higher risk for complications, and also then patients with pain have a worse patient experience. So when we go back to our algorithm, the first question when we have a patient with pain can be, what kind of pain does my patient have? The International Association for the Studies of Pain, they updated their definition of pain in the year 2020. Of course, pain is still very subjective and it's individual, but they also defined a new type of pain. We have now three types. It's the nociceptive pain, the neuropathic pain, and the Nosey-Blastic pain. The nociceptive pain can be divided in somatic and visceral pain. Somatic pain comes from either superficial or deep free nerve endings from our skin or our muscles on joints. Then it is transmitted by these fast A-delta fibers to a specific localization in our brain, the somatosensory cortex. On the other side, the visceral pain, which comes from our hollow organs and the peritoneum, is transmitted by slow C fibers and in several areas in our brain, for example, the limbic system. And this underlying physiology, we have somatic pain with a specific brain area and visceral pain with several brain areas in the end. This explains the manifestation of the pain. The somatic pain is persistent, it's well localizable. On the other side, the visceral pain is not well localizable, it's dull and often colic. The second pain type, the neuropathic pain, this arises from direct nerve injury, for example, from nerve transection or compression by a tumor. And the pain characteristics are typically a sudden shooting, burning pain along the anatomical course of our nerve. The third type, the Nosey-Blastic pain, our new pain type, is usually widespread. It's in several body parts. It's intense. The mechanism of this pain is not fully understood. It's most likely a dysfunction of our CNS. Some people also call it central sensitization. And the example is fibromyalgia. What do you think, when does perioperative pain management start?
It depends on the patient. If he has, I don't know, painkillers at home, maybe starts before the operation.
Yes. What I want to highlight in the next minutes is that preoperative pain management starts before the surgery. It's nice to get to know the patient. It's good to have some characteristic about his pain. If he has pain before the surgery, to know the patient's history, the diagnosis, what are relieving and what are increasing factors. Also, what can help is the patient's current medication. For example, does he already use opioids, which can be a hint for chronic pain patient, because this study from 2014 showed that chronic pain patients and also younger patients are at a higher risk for postoperative pain, regardless of the procedure. Of course, after a major surgery, the risk is also higher. But regardless of the procedure, these two groups are at higher risk. In total, we have like five phases of perioperative pain management. I just want to summarize the next two phases. We have the immediate preoperative and the intraoperative phase next. They are mostly managed by our anesthesiologists, and I talk about that later, a bit more in detail. In the immediate preoperative phase, what can be very interesting is what a study from 2015 showed. They showed that a single dose of a preoperative acetaminophen can decrease the risk of early pain after surgery and postoperative opioid consumption. And then after the surgery, the cornerstone in that phase is a multimodal strategy. This employs, of course, our painkillers, but also our non-pharmacological pain relief therapy mechanisms such as physiotherapy or breathing techniques. And in this phase, particular attention must be paid to our elderly community, which is at a higher risk for drug-drug interactions and also postoperative delirium. So in postoperative phase, it's all about the drug-drug interactions. And then the last phase, this happens before and after discharge. Here we can educate the patient about how they can treat their pain, and also in case of we have a chronic pain patient and a very complex situation, it can be very useful to involve a pain specialist outpatient. When we go back to our algorithm, now we figured out what kind of pain our patient has. For example, he has nociceptive pain. The next question in treating his pain is, what is the function of my patient's organs, especially the function of the kidney and the liver? Why is that so? Because most of our drugs are metabolized by these two organs. And after figuring out what function of the organs is, the next question is what kind of non-opioid analgesic can I give my patient? And then we go to the WHO pain ladder. The last decades of pain management were influenced by this ladder, which basically consists of the 3 steps. The step number 1, non-opioid analgesics, and step 2 and 3, the weak and strong opioids, respectively, always together with step number 1 and our adjuvants. But when we talk about perioperative pain management nowadays, we can add another step, the step number 4, with all these nice interventions from the anesthesiologists, such as PCA pumps, epidurals, etc. And when we talk about surgery, it's more a step down therapy. So we start high and go low. And I just want to talk shortly, one sentence about the adjuvants. We should not forgive, they decrease the risk for the side effects, such as the PPIs for stomach protection and the laxative for preventing the constipation after giving opioids. And the co-analgesics, this is, for example, the GABA analogs, they gain more and more importance in treating the second type, the neuropathic pain. The principles in treating pain are still the same. It's individual. We have to consider comorbidities, allergies, interactions, and also personal experiences. Some patients like one painkiller more than the other. And the adage, by the mouth, by the clock, and by the letter still counts. That means by the mouth means, we should prefer oral medication and prolonged release medication, because they have a less risk of side effects, they have a later maximum level, and therefore also a lower risk of addiction. When we take the drugs at fixed times, that leads to more consistent drug levels and also to a better compliance of our patient. And treating according to the WHO ladder means we have to or should not forget the non-opioid analgesics. Combination of 2 substances of 1 active substance group should also be avoided, because this increases the risk of side effects. When we talk about step number 1, the non-opioid analgesics, I only want to focus on the most relevant things now and not so much about dosages. Please look into literature. For that, in step number 1, we basically can diverse the non-acid and the acid analgesics. The non-acid analgesics have an analgesic and an antipyretic effect. We have, for example, the acetaminophen, which we know as paracetamol, and the metamizole, which is still used by some countries. And metamizole has an additional spasmolytic effect. The acetaminophen does not really count as a very strong painkiller, but it's very well tolerated, can be administered in several ways till a maximum dose of around 4 grams a day due to its hepatotoxicity. So when we have a patient after liver surgery or with a liver disease, we have to adjust the dose of it. The metamizole, with the additional spasmolytic effect, which can be quite interesting for patients with renal or biliary colic, is known for its side effect, the agranulocytosis. It does not occur very often, but it can occur after long-term use. And the 3 other side effects, such as hypotension after fast IV injection, impairment of the kidneys, or anaphylactic reactions, they can also occur. The other group, the acid analgesics, they have an analgesic, antipyretic, and antiphlogistic effect. Due to their acid characteristic, they work on a local level and can lower the inflammation process. The so-called NSAIDs, non-steroidal anti-inflammatory drugs, we have several of them. We have short-acting, we have long-acting. Short-acting like the diclofenac, which is very good for pain which is associated with fractures or soft tissue damage. But on the other side, they also have some side effects. For example, they can cause gastrointestinal bleeding, ulcer. They can cause, or they are associated with higher cardiovascular risk and also impairment of the kidneys. Further, a study from 2018 showed that this kind of drugs, the NSAIDs, they're associated with a higher risk for anastomotic leak after colorectal surgery. But to clarify that further studies are necessary. And then after we gave the non-opioid analgesic, we can ask ourselves, does my patient need an opioid? If you can answer this question with no, that means my patient does not have more pain, which is good for him. But 6 hours later, when you're not in the hospital anymore, it can be that he has pain suddenly, and so it would be good to have at least a reserve drug. And I don't want to stop my presentation now, so our example patient has pain, and we want to give him an opioid. So what do I have? I have step 2 and 3 now of this ladder. Step number 2, the weak opioid, for example, we have the tramadol. Tramadol has several advantages, since it's available in several administration forms, and it's very easy available. For example, here in Switzerland, I don't have to fill out the so-called Betäubungsmittelrezept. But on the other side, especially in first-time users, the tramadol can cause severe nausea and vomiting. Then the third step, the strong opioids. The reference substance of them is the morphine. We have several of them available right now. For example, the strong fentanyl and the sufentanil, and the fentanyl is available in forms like lollipops and acute nasal sprays, for example, in acute pain. And when we give these strong opioids, we have to consider some things. The dosages are individual. For example, chronic pain patients have a higher need of these drugs, and but when we administer them intravenous, it should be slow and, in best case, with hemodynamic monitoring. Combinations of them with benzos and MAO inhibitors are associated with a higher risk for the side effects, and in worst case, we have an antidote, the naloxone. Side effects of them are, for example, nausea, vomiting, obstipation, sedation, also respiratory failure and tolerance. And for nausea and vomiting and also the obstipation, we have the adjuvants to prevent them. Yeah. The last question of today is, when nothing helps, is do I need to escalate? And then I have today the step number 4. the nerve blocks, the epidurals, and the PCA pumps. I want to focus on these three methods now. Of course, there are a few other methods available right now, but a cornerstone of today's perioperative pain management therapy is the PCA pump, perioperative patient-controlled analgesia. The huge advantage of that method is that the patient can control the pain by themselves, and that leads to an independent control over the pain. However, this method needs the patient's compliance. So in a comatose patient, I cannot use these methods. While using a PCA, we should still give the patient a non-opioid analgesic, because that decreases the requirement for opioids by approximately 40%. The second method, the Iv Ketamine, we know that from the emergency medicine, Iv Ketamine is sometimes used, especially in cancer patients, for the perioperative pain management. We also use not only the analgesic effect, we also use a hyperalgesic effect from the ketamine. And some studies show that it can increase the sensitivity of the opioid receptors, and therefore the requirement of opioids is a bit lower. But this was questioned by a recent meta-analysis. And the last method I'm going to present today, the epidurals, they gain much importance in today's pain management. They have you infuse local anesthetics in the epidural space, and this is then associated with a less requirement for opioids, and also patients who receive an epidural, they can work earlier again. So they have less complications such as pneumonia. On the other side, the epidurals, they have also some disadvantages. For example, a high risk for failure due to exclusion, unwanted spinal anesthesia, infection, which can lead in worst case to a meningitis, hematoma, and in case of intravenous or intra-arterial infusion, that can lead to intoxication. Further, in the last years, there was a huge discussion about epidurals in abdominal surgery, for example, in pancreatic surgery. Some studies showed that there is a worse outcome for patients receiving these epidurals after pancreatic surgery. For example, it was associated in major hepatectomy for a higher risk for acute kidney injuries afterwards. But in the year 2020, a huge RCT published in Summer Surgery compared epidurals with PCAs in pancreatic surgery, and they showed no difference in the primary and secondary endpoints such as pancreatic fistula, bile leakage, and also the 30-day mortality. But what they showed is that these patients who received the epidurals had significantly higher weight after surgery, most likely due to the volume intake, and they also received significantly more vasopressors. And the failure rate of the epidurals was still approximately 20%. That brings me to the end of my presentation. Here you can see a repetition of this pain algorithm, which can help us for our daily work. We can start with figuring out what kind of pain my patient has, then what is the function of my patient's organs, then can I give him a non-opioid analgesic, does he need an opioid, and lastly, do I need to call the anesthesiologist? Thank you for your attention.
Good morning. My name is Dr. Fries. I work for a long time in the pain unit. Just to summarize in a few points, it's important that you know what type of pain it is. Is it neuropathic? Is it nociceptive? Or is it a post-operative pain? Is it important to know if the patient has a chronic pain? Step 2, for example, has the patient before the operation already pain? Is the pain compensated? Or do you need a little bit more pain killers before the operation? These are questions to know. And then he also showed very much intraoperatively. It's important that you know when the pain therapy starts. There should be some, of course, therapy in advance, but also there are many options during and after the operation. He showed very good that there are few options, the intravenously medications, the epidurals, and what he's, of course, because he's not an anesthetist, that there are also a few newer regional options that we call plane blocks. That's, for example, perhaps somebody heard about the muscular recta spinae block, or the top block, the abdominal plane block. These are blocks that you can use especially perioperatively, but you also can do the infiltrations postoperatively. The muscular recta spinal block is especially for the operations in the thoracic place. The good thing is about these are infiltrations that can be done with ultrasound sonography, also under bad coagulation situations. The same is with the top block, the abdominal block. That is more for the abdominal surgery. That's also done by infiltration with ultrasound sonography. And this is also in situations where the coagulation is not good. Just 2 points to the PCA and the IV ketamine. What he left out that, for example, the PCA, especially postoperatively. Of course, you start perhaps in the beginning, but it's something for after the operation. The IV ketamine, and there's also lidocaine that you can give intravenously. That's something that you can give already during the operation, but it's also something that we use or that we offer you on the station.
Okay, thank you very much.